Um, hit the record button here. So welcome to our community group meeting. It's been a while since we've had a chance to meet together and talk about community mission area stuff. Last month I was hoping to be able to present stuff that came out of our community mission area retreat, but there was so much going on, it just seemed to make sense to postpone that, push that back to today. So I want to spend a chunk of the meeting going over that with everybody. As some of you have heard me talk about, we had a strategic illustrator that was present for the meeting, and I'm going to show you her illustrations as we kind of go through things. And then the other thing I wanted to do was just give folks a chance to check in to hear what people are hearing from communities that they're in touch with, kind of get a sense of how folks are going with this. And before I forget, I also want to put a plug in for our community engagement forum, which will be happening next Wednesday at noon. So our CCTSI group will be running that. We're going to have several of our community research liaisons talk about what's going on in their communities and address kind of the question of how we can stay connected with our respective communities that we work in when we can't actually go out and meet in person. So I think that'll be a really good session. So, all right. Well, I'm going to take us to our illustrations. So hopefully everybody can see that. I'm adjusting this a little bit on my screen, and I would just encourage folks as I'm jabbering away here, if you've got questions or comments, please go ahead and type those into the chat window, and I'll try and make sure that I take some time to address those. So this is the first of two large pieces of paper that our illustrator worked on during our convening. And before I kind of launch into what's on this, let me first give a little background on kind of who was there, why we invited the people that we invited, because I know there were some questions about why we didn't include more people from inside the department. And the thinking was that we would basically invite people that we considered to be folks from outside the department, both on campus, within our communities, and even going beyond that, who might be interested in what this mission area wants to do, what its potential strategic opportunities are, and also thinking about folks that might also continue to be ongoing advisors for this group. So Robert McGranahan was somebody he's really in our department, but Robert runs Campus Community Partnership. And so Robert was, it was great to have Robert there. We had Mark Ernest from General Internal Medicine was there. We brought in Glenn Kotz from Basalt, one of our rural practice partners, Merritt Felzine from up in Northeast Colorado. I won't go through and name everybody, but if folks are interested in kind of seeing the list of folks that were there, we can certainly provide that to people. But we had a pretty good group, and tried to also kind of get a mix of backgrounds and that sort of thing. So that gives you a little bit of an idea of who all was there. So I'm gonna increase the size of this so it's a little bit easier as we go through some of the various sections. And let's see if I can move this around. There we go. It actually worked. So I'm going to start over here with this why section. So this was kind of the first thing that we tackled. We had, as a facilitator, Sheldon Romer. Some of you know who Sheldon is. Sheldon is somebody that's facilitated PAC Council retreats for CCTSI Community Engagement Group. Sheldon has also facilitated at least one senior leadership retreat in the department, and has worked as a leadership coach for me and several other folks in the department. So Sheldon's definitely a friend of our work. And Sheldon's first question for the group was, why, when Don reached out, why did you decide you wanted to show up and be here for this retreat? And you can kind of see the things that people came up with. People were interested in well-being, expanding thinking within community, collaborative efforts, seeing those through different lenses, sense of urgency to disrupt failed systems, this notion that practice should exist in community. There's opportunity to do something different in Colorado and support policies elsewhere, elevate community within our department, asked by someone I trusted and knew would listen, and this notion of making the health of Coloradoans better. That was sort of a theme that ran through all of this. So we had a pretty engaged group of folks that were present at this. So we also, I'm not going to spend a whole lot of time on this. One of our icebreaker, actually, even before we got to this, was, if you could pick a superpower, what would that be? And this is just an illustration of that. But then we launched into a little bit of discussion that mirrored something that we did with one of our community group meetings a few months ago, which was to have Larry Green give a little talk to the group, because we had folks from public health, we had folks from other disciplines, folks from the community. We had Larry give his little talk on why is community important for family medicine. And so, as Larry did for us, he talked about the history of family medicine as a discipline, coming out of this perception by the public that they needed access to generalist physicians, and that was slowly dying away. And this notion of family medicine as kind of a social movement, and the Willard Report that came out, and this whole milieu of what was going on in the late 1960s and early 70s around Our Bodies, Our Cells, a book that was out and really significant, and kind of the social movements that were going on during that time in our nation's history. And then this here's the Willard Report, Folsom Report, health being a community affair, and that we really needed to have community as a foundational concept for primary care. And many of you have heard Larry talk about this, so I'm not gonna spend a whole lot more time on that particular part of the illustration, but it was really helpful, I think, for the group on that day to sort of get everybody grounded with, why is this important for family medicine, if you came into the room not already thinking that. Then we moved into this discussion about, well, who are the potential stakeholders? And I just have to say, for me personally, this was the most overwhelming part of the meeting, of the retreat, because as you can see here, I think pretty much everybody was listed at one point during the discussion as a potential stakeholder. And you'll see a little bit later kind of how we narrowed that down a little bit. But, you know, everywhere from, you know, payers, people in academia, agency representatives, folks in community. I mean, this was a little overwhelming. Hospitals, learners, schools, yeah, the list goes on and on. And then we had this discussion about what does this mission area need to do in order to be relevant or valuable? And I thought this was really an important section that we tackled. And you can see here some of the different perspectives. You know, we need to be a convener. Building partnerships and trust was important. Partnerships with teams that include community and community learners. This need for us to do stuff that really matters, that's meaningful, that can get buy-in from all stakeholders. We need to be careful about sharing our story and what our purpose is, and continually work with others to vision that and to get input on what delivery looks like. There was a lot of stuff here too about, you know, this, we can't just sit over an AO1 or even today in our own home offices, but we got to figure out ways to get into the community. That's really important. There was this notion of making sure that we've got good connections across campus. Here again, early wins to provide momentum and get people invested in what we're doing, as well as investors, and make sure we deliver on our promises. There was a sense that we needed to kind of inventory what we're currently doing. And we've done a little bit of that in this group, but that's an ongoing thing that I want to make sure that we continue to do, making sure that we select those that we should be shining a light on. Here's a little light. And make sure those get noticed, move on and embrace another, leverage resources, and then rinse and repeat. So those are the things that folks thought we ought to be doing to become relevant. So I'm gonna zoom back out here so you can see the whole thing. And I'm just gonna pause and see if folks have questions or reflections before we go to the next one.
Hey, Don, this is Linda.
Yeah, hey, Linda.
Hi, everybody.
Thanks for breaking the silence.
I should have waited longer, right? That's the test. I'm just curious under, on the right side, to be relevant and valuable, where it says do stuff that matters, and there's a comment that says the one thing. Was there any more discussion about that? Was there a sense in the group of an area that really, really needs our attention, that would help guide us, at least getting started? Or
you are presaging the next section. So
okay.
yeah, for sure. Yeah.
Great.
Any other questions or reflections? This was all pretty much kind of the morning's activities for that Friday that we met. Okay, well, I'm gonna move along then, and let's see here. I have to move things around on my screen. Stop the share of that, and we'll share this second one. So the afternoon was really focused around strategic opportunities. And before we get to those, which gets really to Linda's question, I want to spend just a few minutes over here on the right-hand side. So this right-hand side of the illustration actually came early on in the morning discussion, and what our illustrator, or what we were asked to do was to, in small groups, imagine and discuss and then draw. We were asked to draw too. To draw what we thought the missionary ought to be known for in terms of core values, in terms of reputation, and then sensory, which sensory is kind of probably the hardest one to explain, but it was this notion of when somebody interacts with our mission area or people involved with our mission area, what should they feel on a sensory level? What should they experience? So let's just dive into that a little bit here. And I'm gonna start at the bottom. So with that sensory thing. So people drew things around trust, that it was really important for people to sense this notion of trust, the importance of interpersonal engagement, this notion of being together with concepts of accepting, being inclusive, the sense of protection and protecting the folks that we work with, that everybody at the table is being heard and seen. People aren't just being brought in as tokens. And I love this, dealing with the shit. Nice little steaming pile of it there that was illustrated. So that was pretty interesting what folks came up with there. Then in terms of reputation, what should people think our reputation is? So there was this notion of expertise, that we should be known as experts in how and why to work with and for community in an equitable fashion and respectfully. This reputation of being open, flexible, and reliable, that we're closely attached to community, and that's not just a passive ho-hum thing, but we're passionate about that. Ferocious was the word that was used. And then over here was this notion that we're thinking we should have a reputation for thinking holistically about community that includes primary care, public health, and mental health as a holistic sort of unitary view. And that we want to be known as being bold, daring, and embracing risk. And that we do that in partnership with others. No pressure. And then lastly here, what should we be known for as in terms of core values? And certainly this notion of promoting equity, being open and transparent. We're open to try things, and we're should firmly believe that everyone has the capacity to lead, and we should make room for everyone to lead. This notion that we're going to make mistakes and others are going to make mistakes, and we should be forgiving of each other and ourselves. Bringing power from the institution to community and sharing that power. We embrace creative tensions. We don't shy away from tough things. We're in this together with folks in community to solve problems. We're not afraid to listen to our dreams and be aspirational. And remember that there are people suffering from all political perspectives. And we need to be careful about that as well. Oops, wrong direction. Okay. So I'm going to come over here then to strategic opportunities. So we took these on kind of thinking about local, regional, and national, as well as internal. So inside the campus, strategic opportunities. And these were also kind of divided up. We discussed these in small groups. So we'll start here with local. And there was a lot of passionate discussion about what we need to be doing in our own backyard and around the communities that surround our campus. And so, of course, the Aurora Commons project came up, and how we needed to be involved in that, and some pretty open discussion from some of our community partners that had concerns that community hadn't really been authentically engaged to date in that project. This notion that needed to change, and there might be some ways that we could take that on. So that was seen as being really important. Regionally, Glenn Kotz brought a resident along who was doing a rotation in Basalt. And that drove some discussion around learners and residency programs. And this notion that our residencies, they're in communities. They serve specific communities. And there was a sense that there's an opportunity there to work with the residency programs and with residents to engage them around learning how to do community engaged work, and that there might be some ways that we could leverage some of the stuff that Perry and his group has done and partner with them to have another round of some of the residency collaborative work around work in communities. There was this sense then moving to the national level, kind of how do we leverage our partners and policy centers, the Farley Center, the Larry Green Center, both came up, and how we might be able to take advantage of what became talked about as bright spots in Colorado. So places where there are developing or already well-developed community and primary care partnerships that we could shine a light on, put some wind in their sails, and show people around the country what's going on and use those as examples. This notion of primary care and public health, how do we make that a real opportunity to bring those together more effectively? Basalt and the stuff that Glenn and his group are doing with their community opioid response grant was one example of that. And the community health tornado, I'm not sure I remember exactly what that was all about. Maybe Robert can help us out with that one. When we get down here to the bottom, we can come back to that. And then internally, there was a notion that we wanted to see if we could get the chancellor and our deans to champion this work. There was a sense that there's a lot of interest right now in community across campus, but that our resources aren't necessarily aligned, and we need to see what we can do to help get those better aligned. Let's talk about the medical school curriculum reform and how community is getting infused to some extent into that. Some of these pillars here of community wellness, public health, population health, and primary care that all tend to compete for funds a little bit. And how we need to make community engagement more visible on our campus. I'll stop there. Any questions or comments? I lost the chat window. Nobody's asking questions. That's okay. All right. I'm going to move on. And we came up then after all of that discussion with essentially 3 strategic priorities for the mission area. The first of those was to really build a team and figure out who is with us, how we can kind of work together. We talked about some of the possible assets that we have, both in our regional health connector resources, evaluation. Everybody at the meeting said we're in. We're happy to be part of an advisory board, but maybe we should even get a little bit more diverse on that. So that was one strategic priority, really building our team. The second one was we got to focus on our community here. We've got to make a long-term commitment to that, and 2040, investing in that, community campus partnership, making sure that when we're out elsewhere in the state, that we can have a good answer for the question when people say, hey, what are you guys doing in your own backyard? We want to be able to answer that question with, let us tell you what you're doing, what we're doing in our own backyard. So that was the thing. And then lastly, this notion of leveraging bright spots. And that was centered around this notion of kind of putting the wind behind the sails of people that are already doing good stuff, nurturing that, supporting that. Again, this notion of building on what's already there, that they don't need to be owned by us, but could be owned by others. And we talked about community engagement. We talked about our PBRNs as being resources for that, etc. So with those strategic opportunities, then we did move into this resource discussion, which is the last thing that we took on. So what do we have to accomplish this stuff? And recognition of the reality is that oftentimes out there around the state, they don't necessarily like us. We've got a little bit of a negative reputation that we've got to work on. And from the community's perspective, they don't recognize the divisions that we do between the medical school, UC Health, Children's Hospital, the VA. They think, hey, they're all one. And we need to realize that. And we're going to need organization. We're going to need leadership. We're going to need to exploit some resources. And we are part of an asset-rich campus with a lot of stuff that we can leverage. I talked about my own 15% FTE and my license to go do stuff. We've got some resources from the Green Edelman Endowed Chair. We've got our community research liaisons. I've been asking for about half of an FTE for a program manager. And with our incoming chair, I have some to-dos in order to put some stuff in front of the incoming chair that we might be able to put into the budget to make sure that we've got the resources we need. And continue to build the case and the science for our community mission. And that's it. So, Emma typed into the chat. All right. Great to see the illustrations. Did you have anyone from the School of Public Health at the retreat? Yes. So both Glenn Mays and Jen Leiferman were there and have committed to stay engaged with us. And I've got a meeting on the books actually in a week or two with both of them to talk about thinking about how we can bring public health and family medicine even more together in the post-COVID world. Tamara, this is terrific. Was it shared with those present? Did they feel that it accurately represented the discussion? So we've, everybody saw this as it was actively being illustrated while we were talking. I know, Robert, you were there. Maybe you can say a word about that.
I don't remember getting this version of it, but you know, this really does represent what the graphic artist was doing as we were talking. So it was pretty cool to see our words being turned into visual images. And I would also say, and that was a really good summary, Don. I would just say that, speaking personally, I was gratified that even though there was some discussion about it, that that we landed on focusing locally as one of the strategic priorities, because I think it's obviously, I'm biased about that, but it's it's really important.
Thanks, Robert. Other questions, comments? So we do have the big sheets of paper. They're sitting in my office over at AO1. We've picked out a spot to actually put them up so that folks can see them. So once we get back to AO1, we're going to get these things posted so everybody can see them. And Robert, I apologize that I haven't gotten these out to all the attendees, but I will do that, these final versions.
And I also, I have no memory of the health tornado or the community health tornado, whatever that one was. Yeah. It was a long day, so maybe it was towards the end of the day.
Montel, you were there too. Do you remember what that was?
I do not.
It was obviously really important.
Clearly.
All right. Well, if folks come up with thoughts or questions after we close, don't hesitate to send them my way. And yeah, it's really fun to be able to share what came out of that and what we can hopefully work towards over the next few months and years. So we've got about 20 minutes left, and I wanted to give folks a chance to talk about what they're seeing in their communities related to COVID, and yeah, what folks are seeing out there. So I'm gonna stop and let a few others talk.
So I'll go. First, thank you for doing that. I think, especially just kind of seeing your work over the last, I don't know how long it's been, year, 18 months, couple years, seeing it all kind of come together, it's really nice. I was in a meeting, and so I'm just going to throw this out here. I sent it out to a couple people. I was in a meeting with some folks that were talking about, there's all this effort for COVID, which is great. And then there's telehealth happening, but then there's the community members that are falling between the cracks, either because they don't have access to ways to engage telehealth. But the thing that was brought to my attention yesterday were patients that are community members that are afraid to go to the doctor because they think they're not supposed to, or they, and so they're seeing an increase in people coming to the hospital or dying at home because they aren't coming in for the things that they normally would come into. And I'd love to hear how people, if there's anybody working on that, or just kind of putting that out there.
Yeah, Robert, do you want to take the first stab at that? I know you've been talking to folks around some of that.
Yeah, we actually haven't heard that, to be perfectly honest. What we're hearing more is through our resident leadership council and other community partners, is which is widely being discussed, are issues around food security and economic security for people who've lost their income. And the Aurora Public Schools, through its foundation, has done, I think, a tremendous job in raising awareness of this and resources, and the district itself in providing food through 16 different distribution sites, not just to APS families, but to anybody that shows up. And the numbers of people that have been served are in the tens of thousands, beyond that. So that's a big issue. And then more recently, which Don and Montel are aware of because of meetings that we've been involved in, we're becoming aware of, as we all are, the increasing disparity in with people of underserved people of color being disproportionately affected by COVID. And locally, and at University Hospital, what that has resulted in is the need to be providing culturally supportive services of a variety of services to the families who have patients in the hospital. And this was sort of brought to our attention when there was an incident with a Somali family that occurred a couple of weeks ago. And Don and Montel and some members of my team got looped into this to talk through with UCH staff, how they could address this. And then subsequently they told us that this was not a solitary incident, but this is starting to, they're seeing this happening where like 40% of their COVID, was it COVID ICU patients, Don? Or COVID patients in general, I guess it's COVID ICU patients, have limited English proficiency. So they're seeing a need for patient or cultural navigators to help families understand the complexities related to the virus, as well as helping them and the providers who are working with them, including social workers, to connect the families to basic human needs that they may have. you know, two of which would be food security and economic relief. So we're in the process of helping them to think through what a response to that would look like, both within the hospital, but then the Community Campus Partnership is also developing a communication approach that would get messages out through video and written materials to the immigrant and refugee communities in languages and in cultural ways that will reach them and that will be kind of break down the complicated information that's out there. There's a lot of information out there, as I'm sure you're all aware. When you go through all of the links that are on, for example, the City of Aurora's website, the 211 website, which is increasingly being pointed to as the clearinghouse for all kinds of links to resources, and Tri-County Health Department and others. But then when you read the materials, it's a lot of it, most of it's in English, and although there's some sites that have translated things, but and it's voluminous. You know, it's a lot of word-heavy text, and we're talking about some families who may not even be literate in their own language. And so all of these kinds of issues, I think, haven't really been thought about, you know, during the initial weeks of the emergency. And now we're starting to see more of that. So we're trying to think through how can we respond to that. So that doesn't really address what Dionysia brought up, but because I haven't personally heard that. But that's what we're hearing and trying to grapple with.
Yeah. Thanks, Robert.
Thank you,
Montel,
Robert. Sorry.
Montel, have you heard any of that?
Oh, yep. You know, I'm hearing a lot of different things in the community. A lot of issues right now. Mostly what I'm hearing from folks is related to the economic impacts of COVID. A lot of community stigma around COVID. So people reluctant to seek care or tell people when they're ill because they don't want to be ostracized. We're seeing a lot of folks with a lot of concern because they live, you know, in a setting where there are multiple generations or sometimes even multiple families living in very close quarters, sharing bedrooms, sharing a bathroom, sharing a kitchen. And of course, these are folks who, if they are still working, you know, are exposed to the public on a daily basis. So, you know, when we're all hearing the same thing, I think, in the news, these are definitely things that are going on. We're also hearing a lot around abuse of renters, especially folks who are undocumented and don't have legal recourse. And they're very, very scared right now. And then, of course, there's just the fear over getting sick and misinformation, not understanding. I think Robert mentioned that there is an issue with literacy, even in one's native language. So written materials aren't always the best. We have issues with folks being able to access online resources if there's a limited bandwidth, or they don't have reliable internet, or perhaps they're sharing a single source of internet connectivity in a household with tons of devices. So those are the main things that are coming up in the work that I'm doing and the folks that I'm working with.
Thanks, Montel.
Mm-hmm.
Folks out in rural, what are you guys hearing from those communities?
This is Anne, and just thinking about what Dionysia brought up, I haven't talked to community members that have said this, but I do have friends who work in the hospital or in the emergency department and have said people are coming in much sicker, not COVID related, but with other problems. So I think that would back up that idea that, you know, people are not seeking healthcare that they need, or kind of waiting until they really have to go. You know, there's no other choice. And I mean, I guess thinking about it, I have had patients, I've been doing all telemedicine, and patients say, well, I definitely don't want to come in, and things like that. So I think there is a general sense of fear. And then also just among providers and different practices, you know, this is economically pretty hard for them. And so, you know, it's a weird juxtaposition of that fear of being exposed, but also not seeking care leads to worse other outcomes, and then also bad outcomes for practices in healthcare institutions. So that's something I'm not sure that people understand, you know, the practice loss of right, kind of regardless of whether it's primary care or specialty care. So just lots of repercussions.
Yeah, and this is Tamara, and I would echo, I think, exactly the same things that Anne is talking about. And you know, there's even situations where there's not a lot of COVID, but they're still in preparation and out of an abundance of caution, significantly decreased in-person visits. I think along those lines, also thinking about kind of not wanting to, we're not eager to have people come in that have any kind of cough, fever, sick symptoms, and not everything is COVID. So I think a lot of those folks are also ending up sicker than they would have by the time that they seek care as well.
And I'm not rural, but I think we're seeing similar things in the more populated areas here, like for example in Lone Tree, and from what I hear, just at the hospital also, in terms of for outpatient visits, obviously volumes are down across the board dramatically, but also, and I don't think we've heard a lot about this, but hospital census, which we're typically used to hearing, that UC hospital census is well over 100%, 102, 111%. Is down significantly. They're nowhere near capacity. There's certainly plenty of COVID patients, but I don't know the numbers on this, but I cannot imagine that the cancellation of elective procedures would make that much more space in the hospital to be able to run at 60 and 70% capacity. So I think one of the stories that we're going to hear about more later, I suspect, is going to be the people who just did not seek care and who could have been seen in our offices, but weren't. But more importantly, who exactly as you mentioned in the beginning, Dionysia, are staying home for things that should be hospitalized and probably not uncommonly dying at home too.
There was actually an article somewhere, I can't remember where I read it today, talking about how the number of in-home deaths related to cardiovascular disease and other sort of non-COVID related conditions have seen a huge increase. I'll see if I can find that article and get it to Mary or Dawn.
Yeah, and that's what I'm referencing to. I didn't do a very good job, but that's kind of, not the article, Montel, but in general. And just us thinking about, because, and we were brainstorming yesterday about how to get information to those community members that wouldn't be in front of a doctor, and thinking about, like, for example, Dominic Martinez, he's got his pre-collegiate folks doing some kind of door-to-door, you know, getting things to people's, you know, in front of them, either, you know, posting it on the door. I know Denver Health does something where they are making sure that wellness visits are being done for, like, they're not canceling those 0 to 3 wellness visits, for also to be able to be in front of the families and educating them that way. And so we're going to be brainstorming on how to get some materials out, of course, utilizing what CCP is doing in Aurora, but just I think we as family medicine are primed to be to help those, because that's the population that nobody, well, I'm not saying nobody, I'm exaggerating, but isn't talking about, the ones that aren't showing up to the clinics. And I think we have an opportunity to be innovative in how we reach those folks.
Yeah, thanks, Dionysia. Mary's been working on a kind of a series of videos that have mostly been just in English, with the notable exception of the ones that Matt did around masks. But I wonder if this might be a topic for that.
Yeah, absolutely. If you all haven't seen those videos, go on YouTube and search for Snowcat PBRN and you can find a list of all the videos. Matt's PPE one in Spanish will be coming out soon. But yeah, we're absolutely happy to take any thoughts or advice on these videos. They're just really brief videos to get out to people with either information or education. So I'd be happy to talk more about that.
Yeah, and Dionysia, if we can be a resource, you know, information-wise to the folks you're talking to, happy to help there too.
Yeah, I have a list of neighborhoods that they're targeting right now, and I was gonna go through and get like regional health connectors, but if you guys could get me like, I don't know, community research liaisons or other contacts in that those communities, I'll get you a list. That would be helpful as a start.
Yeah.
If you happen to be able to get that today, we have a meeting tomorrow that we could talk about that during.
I have it. I'll email it to you.
Awesome.
Great.
I was just gonna share, so my experience and then some of other people that I know through a moms group I'm in here, like a new moms group, was that I feel like initially there wasn't a lot of communication there's really just two main primary practices in Eagle County where people take that have pediatricians and that do well child visits, and I think there was not a lot of communication initially about like well child visits and vaccines and all of that, and so there was quite a bit of confusion about should you keep stay on track with those appointments. But I think just recently, within the past couple weeks, I would say there's been a big improvement in communication and a lot of emails that I've been getting saying, yes, you absolutely should, and explaining what the procedures are for that. So I think maybe initially there wasn't so much of a plan in place, but now the practices here in Eagle County have really gotten on the ball as far as that goes.
That's good to hear. Yeah. Other news or word from communities? I think as you hear things, definitely we do have our DFM community listserv emails that you can post stuff on. That'd be a good place to share stuff that you're hearing, and if there's things that we can do as a group to help address some of those needs, I think we should try to see what we can do to kind of mobilize around that. And we'll try and make sure we keep folks looped in and connected on that.
I actually have a question before we leave. Sorry, it's my dog just to bark just as I'm starting to talk. To Mary, actually, as the CCP moves forward with developing, short videos, what kind of technical assistance might we be able to get from your group? And I don't even know what I'm asking for. Just this is totally beyond my ken.
I can give you pointers, but I'm a one-person job. So if anyone has interest in helping with this video series, join me and help Robert.
Yeah, for my intro one, I just opened up my iPad and hit the record button and started yapping.
Yeah, I figured that's what it's going to be, but just in case there's anything.
It actually worked pretty well.
I can do editing on the back end, but that's kind of what we're recommending.
The tricky thing for us is going to be, we're envisioning anyway, this is the plan, that we're going to be, for more rather than fewer of them, identifying trusted community leaders or from different immigrant and refugee groups who would be the talking head, not us. And that way that can be spoken in the language, number one, and it's going to be culturally appropriate. So connecting with those folks and then making sure they've got the technology and so on to be able to do this is going to be the tricky part, I think.
Yeah.
Robert, are you connected with, there's a, and I want to think his name is Dennis, but I could be wrong and I can track it down. There's a man that I met at like Aurora Chamber, and he was also at the Diversity Summit for Aurora Chamber, who's very passionate about making videos. Like he made the Bridge Houses video, like, informational stuff. Do you know him? I just wonder if he couldn't be like a resource. He lives in the community and might be able to like hop on and do some things for you. They are, but he's very passionate, and they do what they need to do, which is tell the story. He did some interviews with some of the Bridge House folks and had people crying in the room. So.
Well, if you have that, his name or can find it and pass it along, that would be great. Someone on my team may know him, like Mariana or Gabriella.
Okay, yeah, I'll track it down. I know I have a card. I'm worried that it's in my office, but I know a couple people that'll know who I'm talking about, and I'll. Yeah.
All right.
Okay, thank you.
Thanks, everyone. Great to see everybody, and we'll see you next week or next month.